And joining us now on the debate for the full hour tonight, David Kaplan, Liberal MPP for Don Valley East and a former Ontario Health Minister. Lana Fredo, Executive Director of Sound Time Support Services, a Toronto mental health agency operated by users and former patients. Deborah Sherman, Executive Director of the Ontario Peer Development Initiative. Ryan Fritsch, Legal Counsel from the Psychiatric Patient Advocate Office in Toronto. Steve Lurie, Executive Director of CAMH, the Canadian Mental Health Association's Toronto branch, and Dr. Benoit Mulson, Physician-in-Chief at CAMH. And we welcome everybody for being on the program today. We've got a lot to cover, a lot to talk about. First, just before we get to questions, let's put up this graphic here because this is mental health, if you like, by the numbers. Between 15 and 21% of children and youth in Ontario have at least one mental health issue, this according to CAMH. Only 25% of people with mood and anxiety disorders get treatment. Mental illnesses and addictions cost the province of Ontario at least $39 billion a year in funding and lost productivity. Okay, a lot to chew on today, so let us just go around the table here and we're going to start to make a list, because I suspect a lot of our viewers have no idea what's wrong out there and they need to know. Start us off. Tell me one thing that's wrong with the mental health system in Ontario today.
I would say that if I had to choose my little corner of advocacy, that the difficulty with the mental health, with the planning and delivery of mental health services, is that the people who use them are not working in partnership with the people who are doing the planning and delivery, and the people who use them are not engaged enough in delivering those self-same services.
Okay. Continue, please.
Our office, Steve, advocates for the psychiatric patient population in the 10 dedicated psychiatric facilities. And we also provide mandatory rights advice to every psychiatric patient in the province. We do that about 25,000 times a year. We don't speak for the Ministry of Health. We're an arm's length program from the ministry. But we do speak with and on behalf of our client population. When we ask them what's wrong with the system, we hear that the process of deinstitutionalization is an incomplete project at this point.
Which was started, what, 30, 40 years ago?
Well, our office began tracking the rise in community treatment orders, for example, starting in 2001, 2002. And since that time, we've seen a tenfold increase in the number of community treatment orders that are being issued. At the same time, mental health services has not followed this population into the community. They're unable to access services consistently. They're unable to access peer support and advocacy services. So there's a project that needs to be completed here.
Okay, Ryan. Benoit.
I would say that when people realize that they need help for a mental health and addiction problem, it's very hard for them to know where to turn. As a result, many of them do not get treatment. They do not get diagnosed. They don't get treatment. Their problem gets worse to the point where when they are really sick, they show up in an emergency room. And at that point, they access the system. We can treat them. We can help them. But it's a very costly and sometimes painful process. And to me, if you ask me what's the main problem, we have a lot of services, but it's very difficult for people to know where and when to turn for help.
Okay. Steve, before I get your answer, I'm going to fix my intro to you because I blew it. Okay. Canadian Mental Health Association, not CAMH.
Thanks.
Let's get that clarified off the top. Okay.
Well, I'd say the big problem is that 3 in 10 Ontarians are able to access care and the rest aren't. And,
only 3 in 10.
And that once you access care, you may not get what you need. In fact, there are studies that show that over 50% of people don't get what they need. So to me, that's a huge problem. Access to mental health care should be the same as access to any other type of health care. If you broke your arm, you'd get it fixed. If you have a mental health problem, you should be able to get it fixed.
Deb.
I think from my perspective, the problem with the mental health system is that it's not terribly consumer friendly, not terribly user friendly. There exist a number of organizations run by and for consumers across Ontario that have been chronically underfunded since their inception. They could be better utilized. The system does not yet use peer support enough, which has been shown to benefit huge savings, both money-wise and in terms of people's outcomes and in terms of the suffering that people have had. due to mental illnesses. And so I would say a more user-friendly system is what we need.
Okay. David, just a bit of a setup before I get your answer, and that is you are obviously the former Ontario Minister of Health. This was obviously one of the biggest files on your desk when you were the minister. You called a mental health summit together to try to make some strides on this issue.
That's right.
And you have a private member's bill before the legislature right now on an issue related to mental health services. With all of that having been said, what do you say is the...
It's a hard thing to answer about one aspect because there's so many things. But one of the recurring themes that you're hearing from everybody is it seems to me that we're treating a disease as opposed to treating people. And if that one change could be made to change the culture of the way that we interact with clients, with partners, I think as Lana called them, I think that would be perhaps the most profound thing. I think we need to look beyond even just the individual, look to their families as well. Mental health, Steve said that if you broke your arm, you'd get treatment for it. Mental health, though, it has a much greater sphere. It's not just about you get it fixed. I mean, there's a support network. Oftentimes, there's a chronic nature to it, so that it's not something that will be a long-term illness or something that will be with you for a long time. But really, in my opinion, treating the person, the individual, doing things when they're ready. So I may have alcoholism and I may have another problem as well. I may not be ready to deal with them both at the same time, but if I'm ready to deal with one, the system should be there to help me to be able to deal with the problem that needs to get dealt with.
Okay, Steve, let me follow up on your analogy, and David raised it here. You break your arm, you go to the hospital, they're going to set it a few hours later, you're going to be out 6 weeks later, you're going to be back to normal. I mean, you really can't say that about mental health challenges that people have, right? It is not a simple equation like that.
Well, it's similar and different. At the same time, if you needed therapy for your arm, you would be able to get it. If you needed help returning to work, you'd be able to get it. If you happened to be poor and needed a place to live, you'd be able to get it. If you're poor in Ontario and you have a mental health problem and you're living in Toronto, join the wait list of 2,700 people for supportive housing. So it is different, but I think it's really a fact that we have generated a fair bit of political will to spend money on everything other than mental health.
Where are the 2,700 living right now, incidentally?
Many of them are in the hostels, on the street, in boarding and rooming houses that you really wouldn't want a friend or relative to be in.
David.
Well, you have other issues as well. One of the things that you flashed up earlier was around children. If we can identify early enough, a lot of mental health issues are curable. So if we can intervene at an early time, if people only knew what the symptoms were, what it looked like, where they could access help or direct a family member or a friend to be able to get it, that would make a tremendous difference as far as what manifests itself much later in life. And oftentimes some of the complications that arise. And then as Steve says, housing, employment. One of the greatest challenges that individuals with mental health issues deal with is the social isolation, that they're not connected and they lose a lot of their connections with family and with greater society. So it's a much larger problem. It's not a one sort of a magic bullet kind of thing that can solve this. There have to be a lot of different elements.
Benoit, did you want to follow up on that?
I think I agree. There is no magic bullet. But for instance, we all talk about the problem of access and where people turn. Often when people are in distress, they turn to their GP, their family physician. And so one place, for instance, where we could intervene, as recommended in the report, is to help family physician to better first manage the frontline problem that can be managed by non-specialists. And then when they identify a more severe problem, help them to in the process of referring patient to the existing services.
Ryan.
One concern that we had with the report is that it's very much focused still on the health.
Just remind everybody which report you're talking about.
Sorry, this is the recently released report from the Ministry of Health, the Respect, Recovery and Resilience report. It's their 10-year mental health and addiction strategy.
Okay.
One concern that we have is the report is still very much health focused. If there's a crisis in the mental health system, I think it's a crisis that's no longer a discrete problem. As some of the panelists here have said, housing is an issue, getting a job, finding a community, those are all concerns. But there's broader concerns. People with mental illness often come into contact with the police. They're often criminalized as a result of this. An interesting statistic is that the Toronto Police, 30% of the calls that they respond to are to persons who are in emotional distress. This takes 52,000 police officers that have been assigned, 75,000 man-hours, and yet there's only 34 crisis beds for them to refer clients to. So it's a wider issue. I think the report is a step in the right direction, but there's a lot of gaps and a lot of silences about some of these wider systems that also need to be addressed as part of the mental health question.
Just before we go on, I do want to play a clip here because we had Howard Sapers on the program not too long ago, and he's the correctional investigator for Canada, and he was also somebody who told us that there are far too many people in the jails of this province and country who have mental health issues as opposed to criminal issues. Let's play that clip and then we'll come back and talk. Roll tape, please. Should these people be in jail?
Well, two ways to answer that question. The first way is to say, well, of course they should because the court said so. So they were found guilty of an offense. They were convicted. And their sentence is being administered. But the other way of looking at it is to say that there's the question whether or not they're being criminalized for their illness. You wouldn't put somebody in prison if they had a heart condition. Why would we put somebody in prison if what their activity has been is a manifestation of their illness?
Lana, let me put this to you. The Corrections Ministry in Ontario says that 18% of the prison population in this province has a psychiatric disorder, and if you consider female inmates, it's 31%. How come there's so many people with mental illnesses ending up in jail?
Well, I can only speak specifically to the context that I work within in downtown Toronto. And first of all, we have the acknowledged failure of the community mental health system to provide appropriate supports. We have a shortage, we have an acknowledged shortage of housing. We have diversion programs within the criminal justice system that are fairly successful in diverting people some of the time out of the criminal justice system, but those that do end up in the justice system upon release, there's very little out there to continue to support people in terms of their ability to not only get back what they've lost in terms of housing or employment or education, but in many cases to get things they never had in the first place.
So Ryan, is this the easiest place to warehouse them? Is that it?
I think that police and the criminal justice system is an extremely expensive and rather inefficient access point for people to find the mental health care that they need. Our office is seeing a really interesting phenomena over the last year. We're increasingly getting calls from persons who have been found not criminally responsible, which is normally when you commit a crime and because of the mental illness you're not responsible for it. Normally they would enter the forensic mental health system. Never before have we seen this, but now an increasing number of people are actually appealing their NCR verdict to stay out of the forensic system. What they'd rather do is serve their defined time in the regular prison or jail system rather than go into the forensic system for an indefinite period of time. What someone faces when they enter the forensic system is a system of yearly reviews. The goal is rehabilitation, but the lack of services, the inconsistent provision of services across facilities
Means they'd rather go to jail.
That's what we're seeing. Yeah.
Steve.
Well, and that's where I think part of the problem is. Greg Brown just did a study about a year ago looking at who's actually in the jails with mental health problems. And he's a professor of psychology at Nipissing University. And he found that about 6 or 7% have serious mental illness, but another 35% have mental health problems, 66% have addiction issues, 50% are victims of trauma, another 50% have observed trauma. So it really speaks to doing some of the work upstream. You've got people showing up in the justice system who really shouldn't be there, and if they had access to help earlier on, they might not end up there. So
or you have children who are put in special education programs when perhaps they have just help with mental health, or there's family issues that we could, if we could identify, if we could intervene at an earlier time, perhaps we could cure or at least help with some coping strategies to be able to deal with some of these things. Ryan made an interesting point earlier. He said the report, and I'll let Deb speak to it. I mean, she is one of the authors of it. It speaks to only the Ministry of Health, and I don't think that that's a correct reading of the report. It does talk about a number of different areas of government, like the justice system, like housing, like education, employment, social services, that these do need to work together, that they are very uncoordinated.
You hear that all the time, though. Silos in government just don't speak to each other.
And I have a lot of experience with that. When I was infrastructure minister, and I know we've done a show on this before, the way that I developed the growth plan is we brought 8 ministries together. When I tried the same strategy in government, it was over 14 ministries dealing with mental health and addiction services. And our first meeting with the ministers, and they were very enthusiastic about it, said to them, we want you to go back, come back and tell us all of the things that your ministry is doing related to mental health and addictions. At our next meeting, we had more than a few say, we didn't even know we were doing all of these things, or we didn't know we were connecting with other ministries. And what the report speaks to is the need for somebody has to take the lead. Somebody has to show leadership. And the report says, and I agree, that the policy lead should be the Ministry of Health and Long-Term Care, but they're very important partners in all of the other ministries in order to serve the needs of that person and of that family unit.
Deb, do you want to follow up?
Absolutely. It's going to take a lot of interministerial collaboration to get a mental health strategy that's going to work for folks. And there's going to be, I think, the need to do a lot of shuffling of resources and maybe funding from one ministry to another, which is going to be a political storm. But I do think that it needs to happen. I think that with the right services in the right place, you can prevent people from getting into the care and administration of the wrong ministries.
Steve?
I think one of the things that would move it along is a funding strategy. In fact, the government could...
What does that mean exactly?
Well, I'll tell you, the government could spend $160 million a year and add 1/3 of 1% to healthcare spending. And you could use that to put in place housing, interministerial work, more programs with the corrections ministry, work with primary care around earlier intervention. But I think the problem we're up against is that we hear that there really isn't an appetite to fix the deficit in mental health care. That even though only 3 out of 10 people get service, the economy isn't going well, so mental health will have to wait. Well, I think if mental health continues to wait, we will end up spending more money. If you look at the statistics of what the costs of mental illness are to society, $51 billion a year. We spend billions of dollars on law enforcement for people with substance abuse problems. So I think we've got some choices here. And I think, and hopefully Mr. Kaplan can take it back to his caucus, because both the Select Committee and the Ministers' Advisory Group did speak about the need to work in an interministerial way. They did talk about the need to invest in housing, to help people get jobs.
Everybody talks about that. It doesn't seem to happen.
Well, it's like the law of inverse relevance. The more we talk about something, the less we intend to do about it. But I think we have an opportunity to change that in Ontario.
Lana.
But it's very difficult, with all due respect to you, it's very difficult to be positive about, about the potential for interministerial activities to take place when we know that, for example, the Ministry of Community and Social Services, while the Minister's Advisory Committee was working on this report, we know that the Ministry of Community and Social Services, the Ontario government, was in court trying to appeal the Trench-Montagne decision, which allowed,
help us with 20 seconds of background on that?
Which allowed individuals with addictions, which allowed substance users to apply to the Ontario Disability Support Program. So, I mean, there has to be some reconciliation here. On the one hand, we're writing a report about respect, recovery, and resilience, and we're making recommendations to drastically change the mental health and addiction systems, and talking about interministerial cooperation. But at the very same time, the Ontario government is in court absolutely trying to undermine the access of individuals with substance use issues to the Ontario Disability Support
Let me
Program.
get David to see. Was there an explanation for that?
I'm not going to speak for the Minister of Community and Social Services, and you'll have to ask her to come on your show and be able to talk about these issues, particularly if they're in front of the courts. You know that wouldn't be something that anybody would be able to speak to. But I think the point is well made, that there's a lot of moving parts and there's a lot of work. Steve made the correct point, which is that we are vastly under-resourced when it comes to and compared to other nations and other jurisdictions around the world. One of the things I'd like to see is setting a realistic target about how we could be able to increase the proportion that mental health does receive of the healthcare budget. But understand that that's a very difficult conversation.
Sure.
Because it's not just a question, I think, as it's been suggested, that we add more. You're obviously going to have to shift resources away from somewhere else that you're currently spending it. And we all know that we'll always be able to find a good, rational, reasonable reason why we're doing these programs and why we're providing these services.
Let's just give our viewers a sense of the numbers here. The health budget this year is it 50 billion yet? It's almost
47 billion.
47 billion?
Yeah.
And what percentage of that would go to mental health services?
Oh, well, in health, I guess it would be around 4%.
It's about
Steve?
5%.
About
5%.
5%.
Does that number sound about right? Sound too low?
Well,
About 8%.
the Canadian average is about 7.2%. So Ontario.
Of other provinces,
yeah,
you mean?
Yeah. And the jurisdictions that are doing a good job are spending 10 and 12%. So we have a ways to go. But the provincial government will actually get $1.95 billion in health transfers, increased health transfers from the federal government between now and 2014. So they could, if the political will was there, make a down payment on some of these reforms.
Well, you just got to hold on a second, because $1.9 billion, in fact, the money, those are the monies that Paul Martin had originally put out. In fact, those are declining and end in 2014, and they have already all been committed to other areas of the healthcare system. So
That's why they're saying we're going to have a fight about this.
While I'm saying, this is under-resourced, I mean, you're taking away from something else.
Okay,
Cancer
Benoit.
care from something.
I think, it's very interesting to me as a mental health professional. People, the general public, they care a lot about their knee, they care a lot about their cataract, they care a lot about their heart, they don't seem to care about their brain. So that's really what we're talking about. It's not just a question of politicians fighting with other politicians. I think everybody around this table would agree that the mental health care system is under-resourced. If we have to transfer some resources from one part of the healthcare system to the other, we need to convince the general public that it's worthwhile. And people, because of issue of stigma and discrimination related to mental health, people don't want to imagine that they will ever suffer from a mental health or an addiction problem, and a loved one will ever suffer from an addiction mental health, even though it's probably much more likely than suffering from many other problems.
Benoit, while you've got the floor, let me read this to you. I'm sure you saw Kirk Macon's series in the Globe and Mail about this, and you may not have been too fond of some of what it had to say. And I'm going to quote one of those sections that you won't be particularly fond of, but I want to give you a chance to speak to it anyway. Many critics accuse CAMH, where you work, of focusing too much on patients and treatments that will enhance its international reputation at the expense of unglamorous forensic patients. Toronto Defense Counsel Chris Hines said that CAMH frontline workers pay the price for decisions made by the center's privatized board of directors. Everyone just buys their disingenuous claims about funding, he said. Quite frankly, they are more interested in helping you grieve over your dead pet than they are about psychotic people. The real reason they don't want to accept people is they don't want CAMH to turn into the Don jail. Okay, I know you don't speak for the board of directors, you're here speaking for yourself, but do you want to have a response to that?
I don't really want to have a response to that. There was a very good response sent by your CEO that was published as a letter in the Globe and Mail. It's just not factual. Actually, the number of forensic beds at CAMH over the past decade have more than quadrupled. And the biggest program at CAMH currently in terms of inpatient is the forensic program. CAMH also is really dedicated to, we're a specialty hospital dedicated to people with severe and persistent mental illness, schizophrenia, bipolar disorder, severe depression, Alzheimer's disease. We really have no service that offer grieving for people who lost their pets.
Okay,
So
but the criticism seems to be that regular hospitals can't turn away the neediest patients who are in most desperate need of help, and the suggestion is you guys are.
We don't turn away the most people in need. We have several thousand admissions every year. We have the most busy psychiatric emergency room in the city. So it's just not factual.
Okay, David?
Well, I think Benoit makes not only a really good point, but one of the real, I think, reasons for optimism is the transformation that's taking place currently at CAMH. If you look at the way that site had originally been developed, it was to isolate it from the rest of the city. The transformation that's taking place, that I think is very exciting, is to reinvigorate, to make that and to reintegrate the CAMH as a part of the city, where people who are patients, where they're family members, they can go and get help and treatment, but then they can also leave and also become part of the city as well. And I think that's something we should celebrate.
Benoit, let me ask this question, because we did a program on CAMH a few years ago, and somebody who was on that program told us it's the only hospital in the city that doesn't have a gift shop, which says a lot about whether people are welcome to come, whether they're welcome to help buy something to make somebody who is staying there feel better. Is that still the case?
That's the case, but that's not because CAMH doesn't want one. It's because, as you're pointing out, and I've mentioned, because of the discrimination and stigma. If you have a heart attack and you're hospitalized, your loved one will come and visit you. If you suffer from a severe depression, your loved one will wait until you're discharged. So a gift shop could not survive at CAMH.
Okay, Lonnie, you want to follow up on that?
Well, I wanted to speak specifically to, and it's a criticism I have of the report and of this notion of people being included into the community, put back into the community, becoming part of the community, because it is...
What does the community mean?
Well, it's slightly offensive, because the fact of the matter is people who are using mental health services or have used mental health services in the past are indeed part of the community. They have to get groceries. They have to go to the laundromat, and so they have to get their income tax done. They have to do whatever any other person who is a part of a community. So this idea...
Sounds like when they get out, they're not released into the community. They're released into living in the streets or hostels or something like that. That's not exactly the community.
It's not the community, but I also resist the idea of portraying individuals who've used the mental health system or who are using the mental health system as somehow an adjunct group to the community. Because the fact of the matter is, when they aren't in that bed for 3 or 4 days at CAMH, they are moving through the community.
Steve, do you want to speak to that?
Well, I think it's very much about the notion of citizenship. I mean, everybody in Ontario and Canada has a right to decent health care and also has a right to decent supports. In fact, the federal government has now signed the Convention on Disabilities, which suggests that people not only should be getting access to treatment, but they should have access to housing, to work. And so I think, to Lana's point, this isn't about segmenting a group of the population. I mean, this is us. It could be our sister, our brother, our aunt, our uncle, our husband, our wife. And in fact, if you take that 20% figure and then say, who does it really affect? It probably affects 80% of the population. So it's not just an us and them, but it often gets portrayed as an us and them issue, which is quite unfortunate.
Deb, let me put this to you, and I read this in the report, and it's kind of astonishing. One woman went to a hospital emergency ward 83 times before she was finally referred to a mental health community crisis team.
Yes.
That sounds outrageous to be happening in this day and age. Why does that happen?
It is outrageous. And I know that the example was used to show a final good outcome, but when you think of all the money that was wasted on all of those hospital visits, when it might have occurred to someone in that hospital to refer her out the first time she showed up.
Why didn't it happen?
I don't know, but I think, and I've just been sitting here listening to, and I agree, it's really nice that several hospitals in Ontario are redesigning and rebuilding, but that's money being spent on a hospital infrastructure when for years we've been told that mental health needs to be in the community, and the money is still not following into the community. So, we are the community. We're 20% of the community at least. So we are the community.
When you say we, you mean people who are
People who
dealing
have
with mental
had mental
issues.
health issues.
Okay.
We are the community. We
Ryan.
are.
I just wanted to pick up on what both Steve and Deb were saying. I think the best way to help someone find stability in their life is to make them an active participant in their care, to make them a full citizen with the same rights and ability to direct their care like anyone else would enjoy.
That's not an option, though, for everybody with mental health issues, though. Isn't that fair to say?
Well, as a rights advocacy organization, Steve, we think that you should never give up on that option.
Okay, but where the rubber really hits the road, I mean, is that really true? Not every person suffering from mental health issues can be in charge of their own recovery program.
I disagree with you, actually. And I think that everyone at every step of the process should be offered that option. There was a coroner's inquest in 2008 into the death of a man named Jeffrey James. He died after being in restraints for 5 days. And one of the key recommendations that came out of that is that there was a barrier between the treatment team and this clearly seriously disabled and ill man. One of the key recommendations that came out of that was the role that advocacy can play in bridging the gap between the treatment team, which has its own set of obligations and duties, and of the patient. The recommendations went further that said advocacy should be available to everyone in the province, not just the 10 dedicated psychiatric facilities. And I think when you look at the rationale for these recommendations, one of them is that it can save the system a lot of money. If you can help people to become active in their care, to take ownership of their care, then you've got someone who will proceed more quickly through the system and who will find lasting stability.
That makes sense on the face of it. Benoit, I'm going to ask you the same question. Is that something that is a reality for everybody suffering from mental health issues?
Everybody who suffers from mental health issue, even the sickest patient who are hospitalized, should have a chance to be involved in their care. Now, some of them don't have the capacity to make decisions. You know, if you are very severely psychotic, you may not be able to make decisions. We have a framework in Ontario, which is pretty much the same anywhere in the Western world, where you can have a substitute decision maker who typically will be a first-degree relative, a loved one. If you don't have any, we have a system of guardianship, of public guardianship. But even those patients are rare. The vast majority of patients make decisions for themselves. They are involved in the treatment. I think we have drifted a little bit, and to bring back the discussion to a more global level, not necessarily focusing on the small flaws or a small number of patients. I think we need a strategy. We need a global strategy.
You've invited me there. Let's go there right now, because we've been talking about this report, a 10-year plan, looking forward to try to fix things. Let's do this right now. We've got some graphics with some of the bullet points from this. Here's the overhaul, the 10-year strategy, which will establish a mental health and addiction council. More on what that would be in a moment. Provide more community-based care. We've heard a lot about that so far. Integrate housing, employment, and health services for patients. Aim for earlier intervention in the cases of mental illness and addictions. That is from the Respect, Recovery, and Resilience December 2010 report from CAMH. Okay, David, to you first. This Mental Health and Addiction Council sounds like another level of bureaucracy. Is it, or would it be?
There's definitely a need for some coordination to go on here. I mean, there's so many different aspects and elements. I think it's a good idea. The Select Committee talked about having an overall agency like a Cancer Care Ontario type of agency, determining what kind of services could be provided on a regional basis, and then putting some benchmarks in place. How do we monitor and know that in fact we're making progress toward improved and better services? So, you know, it's the whole question of leadership. And I think that's what the authors are getting at when they're saying we've got to have a council, we've got to have somebody.
Okay, let me clarify two things here. Number one, that's an Ontario report, that's not a CAMH report. Number two, you made the analogy for Cancer Care Ontario. When the government created Cancer Care Ontario, suddenly we have a much more rationalized, much more sensible, much more, if you've got cancer, you've got a better shot in Ontario now of recovering thanks to Cancer Care Ontario.
Well, in fact, much better access, much better rates of recovery. We're seeing investments in aftercare and programs
so
that
that's
are
the
there
template.
available.
You'd want to bring that template to
It's
mental health.
Obviously different in mental health. I mean, there's so many different facets to it, and as you say, employment, housing, social services, et cetera. But the similar kind of model with a similar kind of overview, and somebody's responsible for making sure that these things are getting done, that it's in place, and that we're making progress.
Steve, this checklist, what do you think?
I think it's a good checklist, and I think, you know, to the point of needing some group that takes ownership for this, that's important. I mean, if you are a $2.5 billion operation within a $46 to $50 billion ministry, you're going to get lost. So the Select Committee said, have a Cancer Care Ontario model. This report says have an Assistant Deputy Minister who is charged with making sure that the LINs, the local health integration networks, and the field work together with this Mental Health and Addictions Council.
Who's in charge right now?
Who's in charge right now?
Who's in charge right now of ensuring that mental health services
thought
are
it was
as good as
David.
they can be? Well, David's not the minister
That's
anymore.
a very loaded question because there's a lot of people in charge. I mean, there's a lot of ministries in charge.
If there's a lot of people in charge, then no one's in charge.
That's
who's
precisely,
in charge?
That's precisely the point. Is that there's far too many, and there needs to be some rationalization. There needs to be somebody who has a clear lead and has the ability to make others, you know, get in line with the plan.
When you were the minister, did you have a parliamentary assistant responsible for mental health only?
No. When I was the minister, it was something that was of highest priority to me, so that I took direct responsibility and met quite regularly with the Ministers' Advisory Group and brought together the different stakeholder groups at the summit and the like.
Ryan, do we need something like that? Do we need, I don't know, a mental health czar, somebody who is in charge and who can marshal all of these different resources?
I think the 10-year strategy report, Steve, is an aspirational document.
What does that mean?
It tells us a lot of things that we already know. It tells us that the system is fractured, that there are a series of silos, that services are distributed across the system. It tells us that mental health touches everything from policing to corrections to social benefits.
Does it give you a
entitlements
map
and so
forward, a roadmap forward?
That's exactly the concern, is that we know what's working right now. There are endless examples of programs that have been in place for years, things like mobile crisis teams, things like supportive housing, things like advocacy. We know what works. What we need is for there to be action.
Deb Sherman.
I think it's really important to remember that this is just a report. It is just recommendations to the ministry, and that the actual strategy will follow. I think folks who are interested in how to operationalize all of this need to be referring to some of the background material that went into this report. So there were 5 theme groups in the Minister's Advisory Group that worked towards this report and met regularly. And there was the Consumer Partnerships theme group, there was early intervention and early identification, there was strengthening the community, there was strengthening the workforce, and I've missed one.
That's 5.
But
Sounds
there
like
were
5,
5 groups, and each one of them produced a heck of a lot of work. There's papers that I hope will be available. I think we were told that they would be made available when this report is. And I think it's very important that those papers be made available to the public and to those who are interested in
Deb,
taking this somewhere.
I don't hear you saying this is a roadmap.
I don't think this is a roadmap. This is recommendations. This is where we want to end up. But this is not
Doesn't tell
the
you how to get there?
complete direction how to get there. There are suggestions, but when it comes to operationalizing all of this, there's a whole lot of depth missing from this. You can't put it all in this report.
Steve.
I think we have to look at the experience worldwide, where, first of all, mental health reform isn't a quick fix. I mean, 20 years ago, David Kaplan's mother was the Minister of Health, and I actually wrote the letter of transmittal for the Graham Committee, which said the glass is half full, but we need to actually continue to fill the glass, and we haven't done it yet. But I think if you look at Italy in 1978 decided to close down all their hospitals. And in certain parts of Italy, they've actually moved to a community-focused system. But it took 30 years, and there are still parts of the country that are lagging behind. Australia has had 3 mental health plans, but most recently they made a commitment to invest close to $4 billion over a 4-year period to keep things going, to develop the evidence-based services that would make a difference. So I think what we have here, both between the Select Committee report and the Minister's Advisory Group, is a pretty good blueprint for government to sign on to. And I think you've got a variety of suggestions about how to drive the change. It's not just having a czar, because we know that command and control doesn't work all that well. We know that what you need to do is build a shared vision amongst hospital, community players, so people have to agree that supportive housing is important and look at how they can support people in supportive housing. They need to work on getting people jobs. They need to ensure access to care. They need to build more of an infrastructure and more funding and more opportunities for peer support.
Okay.
So you really need either the Mental Health Council as proposed or the Cancer Care Ontario model to sort of get people playing from the same page.
Benoit.
I think we all agree around the table that there have been a lot of thinking that has taken place over the past year, that the field is ready for a concrete plan of action with very specific achievable target, some 1-year target, some 3-year target, some 5-year target, some 10-year target. And then there is the issue of then the resources coming either from inside the system with redeployment of resources some resource hopefully from outside the mental health system. But I think there would be a consensus around this table that we are ready for action.
David.
Not just around this table, though. I mean, we've got the entire political class federally. We've set up the National Commission, and to give credit to the federal government. Provincially, we've seen work already on poverty reduction strategies and other kinds of initiatives. There is a lot of will and a lot of people who want to contribute. I guess what we really need, and what you're asking, Steve, is do we have a plan in place that people can rally around? And I do think we have the elements of it. Now, there's going to be a lot of things that are going to happen, in parallel. So it's not sequential. It's not we take this step, we've completed it, we move on to the next. A lot of different things going on in parallel. People working in the community-based services, people working in hospital services, people working in government, people in outside advocacy organizations, and of course, the patients themselves.
Well, let me get to land on
those
that.
Themselves.
All right, you've seen the recommendations, you see where it's headed. It's not a roadmap, but it is a destination. Do you think, therefore, that people who need mental health services in this province should be under the expectation that they can get improved services, say, in 5 years' time?
Well, I sort of use a Google analogy to think about this. So this is Google Earth. Okay. And where we need to be is Google Maps. So it's,
okay.
As Benoit said, within the system, whether it's advocates, whether it's peer groups, whether it's mainstream service providers, people are looking for a way to operationalize.
So let me get this straight. This is the view from 30,000 feet.
Yes.
But what we haven't figured out is actually what streets to take to get there.
No, and I have to say this is my third reform process that I've.
How did the first two work out?
Exactly.
Not well? Is that what you're
So
saying?
I'm here at my third one, right? And each time the failure of those processes has been to move from that 30,000-foot position and to actually give, whether it's advocates, whether it's peer groups, whether it's mainstream service providers, something that they can use to operationalize
Lana,
some of the changes.
why hasn't it happened in the past?
Do you have 2 more shows that you can invite me to?
I don't. In fact, we've got about 8 minutes left, and you can't have all of it. But you know what? Give me a sense of it. What's the biggest stumbling block to getting this thing done?
What's the biggest stumbling block? Well, I mean, there are the obvious things. You get involved in these things. There are changes of government. Governments only think 4 years down the road. I mean, there are those very sort of pragmatic concerns. But ultimately, I just don't think it's ever mattered enough. I just don't think that people with significant mental health problems and substance users matter enough.
I'm going to go out on a limb here. I've known you a while. It mattered to you. I know it mattered to you.
I don't buy Lana's, it doesn't matter. The people that I've run into, whether they're Select Committee or Tim Hudak or Dalton McGinty, I can tell you, to these people it does matter. And
why didn't it happen?
I think that's a hard question to answer. I think there's a lot of reasons. There's not one reason, but there's cultural reasons. Everyone can agree that we should reorganize ourselves, but it's always somebody else who should be reorganized.
So it's turf wars.
It's not me, in part. I think there's larger societal problems. There's a lot of stigma around mental health and addictions. That they're a population to be kept at arm's length. That's not my community, or that's not my family.
That's less of an issue today than it was 20 years ago.
You'd be quite surprised. I think there's an awful lot of work which does need to go on to educate the public around, mental health, what it looks like, what you should and should not be afraid of, and how you could help, where you would refer other people for help in your family or in your friend networks.
Steve.
I think there's a lot of things.
I think we've done this on a small scale. In fact, the Ministry of Health has research that looked at the $200 million that the Liberal government invested and showed that actually the spending there on mental health programs for people in the justice system, more supportive housing, that they worked. They worked for the small number of people who were able to get access to them. And in fact, the point that was made in that research, which I think we have to start with, is that there wasn't enough. Even though the community mental health budget went up by 77%, it actually only meant that a few thousand people got additional services when you have millions of people who need more.
So money is a big
So
deal.
money is going to drive this. Money and evidence base and guidance and partnership and looking at the things we know actually work. Because we actually know far more than we did 20 years ago about the things that work. We know that supportive housing works, we know that assertive community treatment works, we know that peer-operated services work, we know that peer support works. So some of this isn't that we have to start and redesign the system. It's just we have to scale up the implementation of things that have already proven themselves.
Deb.
We know that peer support works, and we have empirical evidence that's generated from Ontario that says so. We also know that peer support is extremely, extremely cost effective because it keeps people out of hospital. It keeps people out of services that are more intrusive, that they may not need yet. There was a study that OPDI and a number of its organizations.
OPDI is you guys,
That's
Ontario
us guys.
Peer Development Initiative.
Ontario Peer Development Initiative. Into peer support and into testing transitional discharge, where people are getting discharged from hospital and being matched to a peer supporter. And it's a long story, but in the end, that study found that among 200 people who got a peer support intervention along with some follow-up from hospital, after the first month, readmission was reduced by 50%. I mean, people getting out of hospital very often go right back in the first month. 50% reduction in that. After the first year, $12.2 million of hospital days were saved. The investment in peer support by the Ontario Trillium Foundation for that was about $500,000. That's 20 times return on investment.
Right.
Deb and Steve, I think, are both exactly right about the need for a more robust system of peer support and advocacy in Ontario. When our office, the Psychiatric Patient Advocate Office, was opened up in 1983, Ontario was a world leader in providing these services. At this point, Ontario is falling behind other more progressive jurisdictions. The United Kingdom has a statutorily mandated advocacy system. Any psychiatric patient in the system can call on them, they can get assistance, they can connect them to services, and they can perform many of the functions that this 10-year report calls for, such as a system of oversight and recommendation. California, the same thing. They've created a statewide system of advocacy.
Which province is better than us in Canada?
As I'm aware, Ontario is still at the forefront in Canada, but that doesn't mean that we shouldn't always be striving to be world-class providers.
I think we shouldn't forget what we talked about earlier, early intervention, early detection. That's another way to make our system more effective. And so we go back to the idea of having a plan with a few concrete objectives, because you ask, what's the problem? The problem is we have 20 good ideas, all of them could work, all of them address a different segment of patient or of the problem. We didn't talk also about the integration of mental health and addiction services, since many people with mental health problem have addiction problem and many people with addiction problem have mental health problem. So the issue is if we have 20, and that's the problem with the report, there is about 60 proposals, all of them make sense. We need to be able to agree what are the first 5 things that we're going to do, and we need to do them during the next year or two.
Is there consensus among all of the people who work in this so-called system on what those 5 things are?
Not necessarily.
No. And is that part of the problem?
Yes.
Part of the why I had a summit, and I said to my officials, I want 1,000 people there. We held it in July in the middle of the summer. We had 1,018 people come and register, and we could have had 1,000 more. We need people who work within the system to work together, to want to work together, to want to connect with one another. They're quite disconnected right now. But then also, as Benoit says, develop a common vision. What's something we can get behind? What are the first steps, second steps, and how do we roll that out? That's critical.
Deb, how hopeful or not are you? Lana was telling us this is the 3rd kick at this can. How hopeful are you that this time is going to be the time?
I've survived a couple of those as well. I'm a little more hopeful this time simply because people are describing it as a perfect storm, and I hope they're right. That, with the work of the Ministers' Advisory Group, and thank you so much for starting it, and with the work of the Select Committee and with the work of the Mental Health Commission of Canada, that it's beginning to sound like there's beginning to be more political will behind mental health. So I think a lot of people are very hopeful, but at the same time, a lot of people are concerned because they're not seeing action yet. And I think I think it's true. We need to focus on what are the early wins, what are the things that can be done immediately, that can be done, that will give a good return on investment and that will make an early win for the system. Start there, prove that they work, grow them, and then start on another.
And she's about to have another coughing fit, so we're going to get out of here. That's okay. Lana, thanks so much, everybody, for coming in and helping us with this today, starting with Lana Fredo from the Sound Time Support Services, Ryan Fritsch from the Psychiatric Patient Advocate Office of Ontario, and Dr. Benoit Mulisson from CAMH. On the right-hand side of the table, and on the other side of the table, there's Steve Lurie from Canadian Mental Health Association, Deborah Sherman from the Ontario Peer Development Initiative, and David Kaplan, the Liberal MPP from Don Valley East. Good of all of you to join us tonight here at TVO.
Thank you, Steve.